When you're approaching any sort of case where you're going to have large stone burden, in my opinion, there's great benefit to using a ureteral access sheath. I actually routinely use a ureteral access sheath, really any stone that's more than about 5 millimeters. This is a rather unfortunate 46-year-old woman who I saw in the office with very severe left-sided flank pain. She was having such severe pain that it was taking her to the emergency room 2 and 3 times in just a weekend. The CT scan had a very characteristic look to me, where there were clusters of calcifications and really not sparing any part of the kidney. And I felt that it looked very suspicious for medullary sponge kidney disease. In addition to that, her history is significant in that she had recurrent urinary tract infections and actually had pyelonephritis, infection of the kidney. So we knew we were dealing with really a complex situation, that observation was not going to be a viable option. I offered the patient PCNL, or percutaneous nephrolithotomy, versus a staged ureteroscopy. And ultimately, I recommended the staged ureteroscopy because I felt it gave me the best access to all of the areas where there was stone present, and it also gave me the ability at the beginning of the case to distinguish between what was stone and what was calcifications in the tissue of the kidney, and without committing her to a maximally invasive procedure ahead of time. So my impression of the CT scan was accurate. This did look very much like medullary sponge kidney disease. The sponge part is basically what you see. You see all of these cavities that are of varying sizes in the renal papilla, and inside those cavities are stones, and they are dark brown or yellow, and they're innumerable. There are other parts of the kidney where you could actually see the urothelium overlining just a hue of a dark brown, which we know is stone underneath. And in order to get those stones out of that duct, you actually have to incise the urothelium overlying the duct. I'm a big proponent of using ureteral access sheaths. The benefits of using a ureteral access sheath is that you can atraumatically access the kidney repeatedly. It saves some operative time getting in and out of the kidney, and it allows for active basket extraction. In addition to that, in this particular case, the patient had a history of urinary tract infection. She had an infection of the kidney. There's actually a fairly good chance that there will be some infection inside the stones themselves. Even though they may not be the infection type of stone, they may be secondarily infected. And so I want to keep the pressure in the kidney extremely low while I'm working ureteroscopically, and this will decrease her risk of having either bacteremia or a sepsis event. So I find the ureteral access sheath to be invaluable in this particular case, and in actually most of my cases where I'm treating renal stones. The way I select my ureteral access sheath, I first take into consideration whether this is a primary procedure or a secondary procedure, meaning does the patient have a stent in already that's passively dilated the ureter, or is it a virgin ureter where we've never had an access sheath in there before. I do a retrograde pyelogram to outline the anatomy, so I have a sense already of how long the ureter is, what the diameter of the ureter looks like. Generally speaking, for primary ureteroscopy where they've not been pre-stented, I use the 11-13 French Navigator Boston Scientific sheath. I have found in my experience that upgrading to the larger sheath often results in not being able to place it because the ureter is not large enough. In secondary cases, or in cases where the patient has had a stent in and the ureter is passively dilated, then I go to the 13-15 French size of sheath. When I think about lengths, I consider gender and height. For most women, I put in the 11-13 by 36 centimeter ureteral access sheath, and for most men, I put in the 11-13 46 access sheath, and this is specifically for renal stones. We can change the length of the sheath if we're dealing with a proximal ureteral stone or a mid-ureteral stone. We can change the length of the sheath. I use the Amplat super stiff wire to put up the access sheath, particularly when the patient has not been pre-stented, because having a little bit stiffer shaft of the wire allows you to pass the access sheath easier. I leave a safety wire on the outside of my sheath when possible, and for that I typically use the Boston Scientific sensor wire. So I always put my sheaths under fluoroscopy. I ask the fluorotech to go to a pulsed low dose mode to try to save everyone radiation exposure. And then I use both the feel on the back of the access sheath, how much force are we using. I also find that it often, if it's going to have any resistance to passing it, often it's at the ureteral orifice, and if you just twist a little bit as you're pushing the sheath forward, so like a twisting motion forward, often that will make it slide up very nicely. And I just looked that the ureters not bowing and that we're in a straight line over the wire that we're passing it over. So in this particular patient, you can see the sheath placed at the ureteropelvic junction. I like to have a very systematic approach when I get into the kidney, meaning that I start at the top and I work my way down, and that way I know that there's no area of the kidney that I haven't seen. And so we ended up at her first procedure essentially removing all the stone from the upper half of the kidney. When I looked in, there wasn't a single stone that was loose in the collecting system. So all of the stone that was seen on that CT scan was embedded in these ducts. And you'll see me using the laser where I actually either open the urothelium over one of these ducts or just widen the ducts a little bit, and the stones will just fall out like a waterfall. And then when there's a significant amount of stone in there, then we switch back to the basket, and I end up using a 1.9 zero-tip nitinol stone basket to grasp all of those pieces of stone out. And that's what we did in this case. We ended up taking at least 100 stones out of this patient's kidney. I think this is a very nice case of illustrating where the dusting technique, while very popular now, isn't applicable to every stone. These stones need to be removed with a basket. You know, we were incredibly lucky. She did not have any infectious complications, no fevers. We ended up leaving a stent in between her first and second procedure. That was about 10 days that she had to stent. We came back, finished the procedure, and actually on our second procedure, we left her without a stent, so that was much more comfortable for her. She had follow-up imaging at her 6-week appointment. There's very little of any stone remaining. What we left is really deep down in the tissue. What's surprising more than anything else is how much we improved her pain. Dr. Stuart Wolf published a very nice paper where he looked at patients who had severe pain from ductal calcifications or papillary calcifications. And when they went in and released these calcifications from the tissue, the patient had significant improvement in their pain. And so there's data to support what we're showing here. So I think that the concerns about ureteral access sheath causing trauma to the ureter, while there are some stunning pictures that have been published that show some mucosal injuries, I think the long-term data, particularly from the Crow's ureteroscopy study, has dispelled any myths that ureteral access sheaths are dangerous. The complication rate and stricture formation rate if you're using ureteral access sheath is no different than when you don't use a sheath. So I think that we can feel very comfortable using access sheaths when they're placed appropriately.